BaxHTN, efficacy and safety of the aldosterone synthase inhibitor baxdrostat in patients with uncontrolled or resistant hypertension. Patients with uncontrolled or resistant hypertension are at high risk of cardiovascular morbidity and mortality and adverse renal outcomes. Aldosterone dysregulation is a key driver of uncontrolled and resistant hypertension and hypertension-mediated organ damage. MRAs can block the mineralocorticoid receptor-mediated effects of aldosterone, but their clinical utility is limited by dose-dependent adverse effects. Baxdrostat is a highly selective and potent aldosterone synthase inhibitor, so this trial set out to assess its efficacy and safety of baxdrostat. This trial addressed multiple questions. After eligible patients went through a 2-week run-in, they were then randomized to placebo, baxdrostat 1 mg or baxdrostat 2 mg. Thereafter, they were randomized to baxdrostat 2 mg open label for 12 weeks to prepare for the second part of the trial, which was a randomized withdrawal after 24 to 32 weeks. So the two parts of the trial are the primary outcomes in part 1 and the randomized withdrawal part in part 3. So these patients were all over the age of 18 with a mean seated blood pressure of between 140 and 170 millimeters of mercury at randomization. This is despite treatment with maximally tolerated doses of either 2 medications for the uncontrolled hypertension group or 3 or more for the resistant hypertension group. They must have had a diuretic as part of the therapy. eGFR had to be above 45 and serum potassium within normal range. The only key exclusion criteria which is different than usual is that patients cannot have received the use of an MRA. So here are the baseline characteristics. 73% had resistant hypertension, 27% had uncontrolled hypertension, 62% were male, 63% white, 26% Asian, 7% black. Mean age was 61 years. The clinical characteristics at baseline were similar across treatment arms. Baseline blood pressure was 149/87. Mean number of background medications was 3. Almost all subjects were on diuretics. So after screening 2,591 patients at then the subsequent run-in period, ultimately 794 patients were randomized for the 12-week double-blind treatment. In the patients who received baxdrostat 1 mg, this is a substantial reduction in systolic blood pressure with 14.5 millimeters of mercury, and in the patients receiving 2 mg, there was a 15.7 millimeter reduction in blood pressure. This led to a 8.7 millimeter mercury placebo-corrected difference for the 1 mg dose and a 9.8 millimeter mercury for the 2 mg dose. So they looked to see if there was any heterogeneity or general applicability of this aldosterone hypothesis. And as you can see here, there do not appear to be any evidence of heterogeneity in all the subgroups listed. The key secondary endpoint was randomized withdrawal, and that was a fundamental part of the study, which was actually mandated by the FDA. So by week 24, patients on 2 mg of baxdrostat had a blood pressure of 133 systolic. They were then randomized to receive withdrawal treatment with placebo or continue with 2 mg. Those withdrawn treatment blindly had a modest rise in blood pressure of 1.4 millimeters of mercury by the end of 8 weeks. Those who continued with baxdrostat had a further follow-up blood pressure of 3.7 millimeters of mercury. This was highly statistically significant between the two groups of 5.1 millimeters of mercury. In terms of safety, the adverse events were mostly mild. There were no reports of any adrenal insufficiency. The most common effects were numerically higher for baxdrostat versus placebo and included hyperkalemia, hyponatremia, hypotension, muscle spasms, and dizziness. There were lower rates of confirmed potassium levels greater than 6, around 1%. Hyperkalemia leading to discontinuation was quite low as well. So in summary, in patients with uncontrolled or resistant hypertension, the addition of baxdrostat 1 mg or 2 mg once daily to background antihypertensive therapy led to a placebo-adjusted reduction in seated blood pressure of 8.7 millimeters of mercury and 9.8 millimeters of mercury, respectively, after 12 weeks of treatments. Blood pressure responses were consistent across all pre-specified subgroups. The efficacy of baxdrostat persisted to at least 32 weeks. Baxdrostat was generally well tolerated with no unanticipated safety findings. Rates of confirmed potassium greater than 6 were quite low in both groups.